So now we're going to talk about gene therapy. So it's going to be a bit like the same that we just saw with imicizumab. Dr. TEITEL is going to talk about gene therapy, and after someone who underwent gene therapy treatment will talk. So Dr. TEITEL is a professor of medicine at the University of Toronto and a staff physician in the Division of Hematology and Oncology at St. Michael's Hospital. He is the medical director of the largest hemophilia treatment center in Canada located at that hospital. He obtained his MD degree and pursued residency training at the University of Toronto and then a 3-year research fellowship at Harvard University, where he worked on novel assays for the detection of coagulation activation. His clinical and research activities have been focused in the field of hemophilia and other related bleeding disorders. He is the past president of the CHS, HCDC, and Hemophilia Research Society of North America. He remained active in the HCDC as a chair of its novel therapeutic committee and a member of its inhibitor and database committees. So, Dr. TEITEL.
Thank you very much, Kathleen, and thank you for inviting me to take part in this symposium. Here are my disclosures. I hate to start a talk this way, but I have to start with an apology, because some of you would have been at a breakfast symposium we had early this morning, and I'm presenting some of the same information, so I'm counting on the fact that it was so early in the morning that your eyes weren't open. This will all sound new to you. And like Mark, my remarks are just a prelude to the really important talk, which will come from Jay, who knows this at a level that I can't understand. So this is a little bit repetitive compared to what you've heard this morning from Manuel and Shannon, the current landscape of hemophilia gene therapy. First of all, there are no licensed hemophilia gene therapy products anywhere in the world, but there are approximately 13 clinical trials now recruiting. Last time I checked clinicaltrials.gov. And they have all shown positive results with no major toxicities. So this is here in clinical trials, some of them phase 3, advanced clinical trials. Access to these trials is competitive, and it's difficult to get patients on these trials. But the prospects do seem positive for regulatory approval, at least within some areas, the United States, perhaps in Europe, within 1 to 3 years. So I think this is coming soon. I'm also, like Shannon, very poor at the crystal ball. After the factor VIII and factor IX genes were cloned in the early 1980s, I confidently told my patients, we're going to have gene therapy by the year 2000. So that shows you how good I am at predicting. So what is the upside of gene therapy for hemophilia? Well, the upside, first of all, is the prospect of long-term or even permanent, partial or even complete reversal of the congenital deficiency. And concomitant with that, we can see clinical improvement and freedom from the need for replacement therapy. So it's not I wouldn't call it exactly a cure. It doesn't change the mutation that the individual was born with, but it's kind of tantamount to a phenotypic cure. On the other hand, what are the downsides? Success of any individual receiving a gene therapy treatment is not guaranteed, nor is it predictable. And for those in whom it is successful, we don't know how long that response is going to last. So far, so good. The earliest gene therapy trials continue to show good responses. But it is the case, at least with the current therapies, that it's one strike and you're out. So failure to respond will make one ineligible for a repeat attempt at gene therapy using AAV. That stands for adeno-associated virus. That's the vector, the little guided missile that's used to direct the gene to the target cell, which in this case is the hepatocyte. And although none of these long-term adverse effects have been seen in either human or animal models, we have to acknowledge that we don't have certainty about any long-term risks, including mutagenicity. So I'm not going to go through these, but just to illustrate to you that there are lots of activities. Again, I pulled this off the internet. Anyone can go to clinicaltrials.gov. You'll see the trials that are ongoing. These are trials which are actively recruiting in factor VIII gene therapy, and these are the ones that are actively recruiting in factor IX gene therapy. And some of our centers in Canada are involved in both the factor VIII and factor IX trials. So what are the uncertainties? As I already mentioned, efficacy, the success, the degree of success, the durability of success will be variable and unpredictable. safeties, long-term safety toxicities are possible. We not infrequently in gene therapy trials see early liver dysfunction, a transient elevation in liver enzymes, which seems to be easy to control and transient. However, it is often coexistent with reduced expression of the transgene, that is factor VIII or factor IX expression, so it may interfere ultimately with the response. And then availability. Unfortunately, there's a high prevalence of pre-existing antibodies to the vector used to deliver the factor VIII or factor IX. That's because the AAV, the wild type, the natural AAV, occurs in nature. Many of us have encountered that virus. Doesn't really make you sick. You don't know you've had it. But if you've had it, you've developed antibodies. We can't use that as the delivery tool to deliver the gene. So there's a high prevalence of these so-called neutralizing antibodies. As I already said, regulatory approval dates are unknown, and the production capacity will be limited. We're used to the fact that we've got all the factor VIII and factor IX in the world that we need. So cost may be a problem in some geographies, but availability is not a problem. That's not going to be the case with gene therapy. It's difficult to produce these vectors. It's not like having these enormous fermentation vats churning out factor VIII. It's difficult to make them, and production capacity will be limited. So in a small market like Canada, what will the availability be when we first see licensed products? We can't really predict that. And finally, and importantly, costs and reimbursement are not known. Other gene therapy products in other diseases, rare diseases, have had very limited acceptance. Not necessarily entirely because of cost, but certainly that has been part of the problem. So I do have a question for the audience. So those of you who are with me, please pull out the phone. And the first question is, what should our goal be for gene therapy? Should it be annual bleeding rate? Should this be the main thing we're looking for? Or should it be a predefined clotting factor level? You may think that both of them are important, and clearly they are, but if you have to choose one, forcing you to choose one, which is it going to be? So annual bleeding rate. Well, that's interesting. And in fact, most of the gene therapy trials were designed using that annual bleeding rate as the primary endpoint. Some of them are now actually using both variables, at bleeding rate and a predefined clotting factor as a simulated or as a marker of freedom from bleeds. So if we do, I'll go on to the next slide. So if we do define success as prevention from bleeding, annual bleeding rate, we have to remember that hemophilia A and B are very similar diseases, but they're not exactly the same. And patients with hemophilia A, severe hemophilia A, tend to bleed more than patients with severe hemophilia B. That's illustrated here on this US data. So it may be harder to achieve success if that's your endpoint in hemophilia A patients than hemophilia B patients. Now, another question, this is the last question I have for you. If we do base our goals, if we do aim to achieve a certain clotting factor level, I'll go to the next question, what should that level be? All right, so pick one, 5 or 10%, 10 to 15, 15 to 40, over 40%. What is our goal? I'm not asking about a realistic goal, what should we aim for? All right, so interesting. So, you know, back in the early days when we were using prophylaxis, or the early days of prophylactic recombinant factor VIII and IX infusion, we thought, gee, if you can keep someone's baseline above 1%, you're doing pretty well. Well, I didn't bother putting 1% here as a choice because I didn't think anyone would like that. So if we do choose a level, what are we going to choose? Many of you have seen this multiple times. You know what this is. This is data from the Netherlands showing bleeding rate, annualized joint bleeding rate, as a function of factor VIII activity. And because, as you can see, that curve flattens and gets near zero in the mid-teens, in the 12 to 15% range, that sort of seems like a pretty good target for prophylaxis, first of all, for trough levels of prophylaxis, as Dr. Carcao was talking about, or perhaps as a goal for gene therapy. However, that's data from one country. there's recent data, surveillance data from the United States, which suggests that perhaps we should aim even higher. These are data from Mike Susi and his colleagues at the Center for Disease Control in the US, and it's broken down by age, but if you focus, for example, on the curve on the figure on the lower left, which is early adulthood, ages 25 to 44. This shows bleeding in 6 months on the y-axis, on the vertical axis, as a function of baseline factor VIII activity, or factor IX activity on the x-axis, on the horizontal axis. And you can see that factor VIII, for example, in the red dotted line, levels don't approach zero, bleeding rates in 6 months don't approach zero until you get in the 30 to 40% range. So maybe we really have to reconsider what our goal would be to prevent bleeding if we're basing gene therapy success on a factor VIII or IX level. And then there's sort of the elephant in the room. Oh, that sounds expensive. So is it expensive? Well, there are a number of considerations that will be in play when we talk about reimbursement for gene therapy. There are the options of looking at performance guarantees to address clinical uncertainties. So, in other words, you pay for success, sort of user pay. Milestone-based contracts based on pre-specified events, so those would be carried out over a number of years. Pooling of risk to manage the overall actuarial risk of the whole population, because there will be claims, presumably. Stabilizing claims and premiums, and to protect the payers, which is going to be important. And even so, there will be a number of questions that will need to be answered. As I've said, what are the outcome measures? What are the thresholds for payment if we're on a contract basis? What about patient tracking and mobility? People move. People don't necessarily stay in the same place. How do you find them over the years and decades? What will the durations of the contracts be? And who's going to shoulder this administrative burden to do all this? Those are all questions. I don't have answers, but they're all realistic questions. However, when we do look at cost effectiveness of gene therapy, there was at least one study that is very reassuring that was published recently, and this looked at a hypothetical cohort of a 30-year-old severe hemophilia A patients followed for 10 years after gene therapy or on prophylaxis. So compared what's the cost effectiveness of gene therapy versus prophylaxis. The model was based on the assumption that gene therapy cost $850,000 US, which seems to be realistic based on what we know so far. It was based on an optimistic gene therapy success rate, however you define success, of 90%. That's the prophylactic schedule, 33 units per kilo 3 times weekly, and that's the prophylaxis cost based on US costs, which generally are higher than Canadian costs, and based on the assumption that prophylactic patients on prophylaxis will have 0.3 bleeds per month. So with those assumptions, the model showed us that the total cost of treating each patient over 10 years would be $1 million for gene therapy versus 1.7, almost double, 70% higher for prophylaxis. And not only that, there were distinct benefits in what are referred to as quality-adjusted life years, or QALYs, 8.33 versus 6.62 for gene therapy versus prophylaxis. So the result was that gene therapy costs less and is more effective than prophylaxis, and the only way you could change that model to make gene therapy come out looking worse than prophylaxis was if the initial cost exceeded $1.6 million, so 60% higher than the baseline assumption in the model. So that, I think, is somewhat reassuring once we get over all these questions of contracts and so on. So what about eligibility? When we do finally get regulatory approval for gene therapy products, those criteria presumably will reflect inclusion criteria for the current clinical trials. As Manuel said earlier, all the trials are restricted to people over the age of 17, so you have to be 18 and over, at least for the current generation, the first generation of gene therapy. It will be restricted to those who have never had an inhibitor, even if the inhibitor has been eradicated, because the clinical trials have done that. Some of the trials will enroll HIV-positive patients if their immune systems are intact, others don't, so the licensure requirements will monitor that, or will reflect that rather. and patients with advanced liver disease will not be eligible for treatment, and those with, as I said earlier, anti-capsid neutralizing antibodies will be excluded. So the context you've heard earlier, I won't belabor this. There have been lots of tremendous advances you've heard already from previous speakers in protein-based therapies, whether it's bispecific antibodies, whether it's antagonists to the natural anticoagulants, whether it's extended half-life or extenuated clotting factor concentrates. But none of these offer the prospect of one and done, which is what gene therapy promises. So is gene therapy the holy grail? We hope it is, and it won't end up looking like the Monty Python version. So thank you for your attention.